Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I am Dr. Muhammad Mansour Abbas Saeed, Associate Professor of Clinical Pathology. In this lecture, I will try to throw lights on the intravenous therapy using different blood components. The aim of our lecture today is to identify the term whole blood fractionation to describe different therapeutic components separated from donated whole blood unit, to know the indications and contraindications of different blood components, and we will also be able to describe doses of different blood components. The take-home message of this lecture is this: blood is the most dangerous medication that a physician ever prescribes. It is dangerous to the degree that scientists call it liquid organ transplantation, with all the dangers of organ transplantation. So as a physician, don't be so generous in prescribing blood or its components, rather weigh it by the scale of gold. Blood fractionation is separating blood into its component parts. The process starts with whole blood unit, which is centrifuged to separate it into different components, namely the packed RBCs, platelet concentrate, fresh frozen plasma, which can be used as is or further separated into cryo and cryo-depleted plasma. So what is the need to separate blood into its components? First, it allows optimal survival of each component. The RBCs, for example, need to be stored at 4 degrees to maintain its viability. But if platelets is stored at 4 degrees, it will lose its functionality and need to be stored at room temperature. As regards the plasma, it needs to be stored at -20 degrees to preserve coagulation factors. The second importance is to avoid the transfusion of unnecessary components. For example, a patient needs platelets but doesn't need RBCs or plasma. The third benefit is that the blood from single donor can treat up to 3 patients, of course each one with different diagnosis. Generally speaking, why should I prescribe blood components? 4 main reasons are included here: to increase oxygen carrying capacity, and this is a function of RBCs; to restore red cell mass, again this is a function of RBCs; to correct bleeding caused by platelet deficiency or dysfunction, and of course this is a function of platelet concentrate; and to correct bleeding caused by coagulation factor deficiencies, and here the function is for plasma. First, we'll speak about whole blood. As a rule, nowadays using whole blood is obsolete and also may be prohibited. However, in heart surgeries, some surgeons insisted on maintaining hemodynamic stability for patients using whole blood units, and we are trying to arrange this in Fayoum University hospitals whenever possible. Recently, the exclusive potential use of whole blood is bleeding episodes which are unresponsive to standard replacement therapy using different blood components. Other than this and cardiac surgeries, transfusing whole blood units is prohibited. Next, we'll discuss the first important blood component, which is the packed red blood cells. Packed red cells consist mainly of RBCs, with minimal amount of plasma required for RBCs nutrition. The main aim of packing RBCs is to recover hemoglobin without causing volume overload that can be very harmful, especially in neonates and in cardiac patients, causing hemodynamic instability. A very important point to consider while transfusing RBCs is to be alert to its high content of iron, which will eventually lead to iron overload and multiple organ damage in chronically transfused patients like thalassemias or in multiple acute transfusions like burns. As low as 10 transfusions can cause iron overload and organ damage, and this necessitates monitoring iron concentration. How to decide whether red cell transfusion is required or not? The most important rule here is that hemoglobin alone is a very poor indicator for transfusion. This is because the primary function of RBCs is to deliver oxygen to tissues adequately. So as long as oxygen delivery to tissues is maintained adequately, there is no need for RBCs transfusion. Oxygen delivery to tissues, or DO2, depends on cardiac output and arterial O2 content. The tissue's oxygen consumption, or VO2, is stable across a wide spectrum of DO2. This means that even with low hemoglobin levels, oxygen consumption remains greatly stable. The RBC's transfusion is only indicated when oxygen delivery is insufficient for oxygen consumption. This is called the critical oxygen delivery or critical DO2. However, defining DO2, VO2, and the critical DO2 is pretty tough. Although depending on DO2 and VO2 is scientifically correct, but it is not practical. Thus the solution here is by defining thresholds. And by thresholds I mean the levels of hemoglobin in different cyst conditions below which RBC's transfusion are usually required, while above these levels for hemoglobin transfusion is not indicated. The guidelines state that if hemoglobin is less than 6 grams per deciliter, transfusion is usually needed, while if hemoglobin is more than 10 grams per deciliter, transfusion is rarely needed. If hemoglobin is between 6 and 10 grams, then transfusion needs clinical judgment and assessment of patient situation. And according to AAB recommendations or the American Association of Blood Bank recommendations, if the patient is stable even if hospitalized or in ICU, the threshold is 7 grams per deciliter. In post-surgery patients, the threshold is 8 grams per deciliter, or if the patient is symptomatic although higher levels of hemoglobin. In chronic cardiovascular disease, the threshold is 8 grams per deciliter. In this slide, we will discuss using packed RBCs in the management of certain common and critical chronic diseases. In thalassemia major, which is a chronic hemolytic anemia, a lifelong regular blood transfusion is required. The aim is to maintain the hemoglobin level above 9 grams per deciliter. In chronically transfused patients, it is of utmost importance to give blood bags that are devoid of white blood cells, either by washing with saline or by filtering with specific white blood cells filters. These white blood cells on the long run will cause major deleterious effects on the immune system of the patient, so it must be removed. In another type of anemia called sickle cell anemia, the RBCs carry abnormal hemoglobin S instead of the normal hemoglobin A. This leads to deformed sickle-shaped RBCs, leading to its destruction and critical hemolysis episodes. The aim of transfusion in this case is to maintain hemoglobin at 10 grams per deciliter and hemoglobin S at less than 30%. Another treatment modality which is exchange transfusion, and this means the removal of person's blood and replacing it with fresh donor blood or plasma. This is indicated in severe life-threatening conditions like ischemic strokes and multi-organ failure in sickle cell patients. Exchange transfusion is also indicated in hemolytic disease of the newborn or fetus, in which an antibody crosses from the mother to the fetus and destroys his RBCs. This condition is potentially life-threatening. Transfusing one bag of packed RBCs is expected to increase hemoglobin by approximately 1 gram per deciliter. Patients should be assessed 15 minutes after transfusion of each unit to determine the need for extra blood units. For neonates, the dose is calculated as 10 to 15 ml per kilogram body weight, which is expected to increase hemoglobin levels by 3 grams per deciliter. Contraindications to transfusing RBCs include acute hemorrhage with less than 20% loss of blood volume, which can be reconstituted efficiently using colloids like albumin or crystalloids like Ringer or saline. The other contraindication is chronic nutritional anemias, which should be treated with specific pharmacological agents like iron in iron deficiency anemia and folic acid or B12 in megaloblastic anemia. The next blood component is platelet concentrates. We have two types of platelet concentrates: the random donor platelets or whole blood derived platelets and the single donor or apheresis platelets. Random donor platelets are collected from multiple donors and it is the type used routinely in transfusion. Single donor platelets are collected from single donor and is used in case of unresponsiveness to random donor platelets. As shown in the box, apheresis platelet unit provides the equivalent to 6 or more units of random donor platelets or whole blood derived platelets. The most important point to know about platelet transfusion is the induction of alloimmunization. Alloimmunization means the formation of antibodies against whole blood-derived platelets, leading to its destruction and unresponsiveness to platelet transfusion. The only management of this condition is the apheresis platelets or single donor platelets, collected from a single donor who must be genetically matched to the recipient. The second advantage of single donor platelets over random donor platelet is its very low content of white blood cells, and this leads to drastic reduction in the occurrence of febrile non-hemolytic transfusion reaction, which is the most common transfusion reaction. The traditional dose for whole blood-derived platelets is usually 1 unit or 1 bag per 10 kg body weights, with one therapeutic dose equal 4 bags. We commonly give 6 bags at a time, then measure platelet increase and reassess patient bleeding condition to decide whether further doses are needed. In units, the dose is usually 10 to 15 ml per kilogram body weight, keeping in mind that 1 bag of platelets contains around 30 ml of platelets suspended in plasma. In single donor platelets, we transfuse the whole platelet unit to the patient. First indication for platelet transfusion is reduced platelet count or thrombocytopenia. Prophylactic transfusions mean the patient is not bleeding, though we will transfuse platelets for fear of bleeding. Our threshold here is 10,000 platelet count if the patient is stable, and 20,000 if the patient has risk factors like thrombocytopathy, which is a defective platelet function. And the threshold is 50% if the patient is about to have major surgery. On the other hand, therapeutic transfusions mean the patient is bleeding, and here the threshold is 50,000 or up to 100,000 in patients with intracranial and pulmonary hemorrhage. The second indication for platelet transfusion is defective platelet function or thrombocytopathy. Thrombocytopathy is a wide group of hereditary and acquired platelet dysfunction in which platelet count may be normal or reduced. Prophylactic platelet transfusion is not indicated in thrombocytopathy. Rather, transfusion is indicated only if the patient is bleeding. Congenital thrombocytopathy include many syndromes like storage pool defects, which is the most common congenital thrombocytopathy. Acquired thrombocytopathy include drugs like aspirin, procedures like ECMO or extracorporeal membrane oxygenation, and chronic diseases like chronic renal failure. It's most important to know that in chronic renal failure, platelets is not the first line of treatment, but it is the last line after trying other therapies like dialysis, DDAVP or desmopressin, cryo, transfusion, and conjugated estrogens. The aim of all these therapies is to stimulate the release of an intrinsic factor called von Willebrand factor, which leads to significant improvement in platelet function. Contraindications to platelet transfusion. Platelet concentrate is the most frequent plaque component to be wrongly prescribed, and unfortunately these conditions frequently lead to patient death. The first two diseases in which platelets are wrongly prescribed are the TTP or thrombotic thrombocytopenic purpura and hemolytic uremic syndrome or HUS. Both are classified under thrombotic microangiopathy, a group of diseases characterized by microthrombi in multiple organs. In both conditions, there is anemia, thrombocytopenia, schistocytes or fragmented RBCs in blood film, plus microthrombi. Thrombotic thrombocytopenic purpura has neurological symptoms absent in hemolytic uremic syndrome, and hemolytic uremic syndrome has advanced kidney injury absent in thrombotic thrombocytopenic purpura. Both have thrombocytopenia and bleeding, and imagine what is the treatment? Yes, it's plasma, which is life-saving in these conditions, whilst platelet transfusion lead to more thrombi and to patient death. Plasma exchange restores the deficient enzyme in TTP while remove the toxin in hemolytic uremic syndrome. Second contraindication to platelet transfusion is heparin-induced thrombocytopenia, or HET type 2, which is immune-mediated compared to HET type 1 that is non-immune. In HET type 2, heparin, which is anticoagulant, binds to platelet factor 4, on the surface of platelets and stimulate antibody formation. This antibody is directed against heparin platelet factor 4 complex, leading to platelet thrombi. Transfusing platelets in these patients leads to life-threatening thrombosis. The first line of management is the correct diagnosis using the famous 40 score. Then discontinue heparin and use alternative anticoagulant, but Platelets that keep away from warfarin. The most common drug used here is rivaroxaban, which is antiplatelet and anti-factor 10 inhibitor. The third contraindication to platelet transfusion is immune or idiopathic thrombocytopenic purpura, in which an autoantibody in the affected patient destroys his own platelets. Actually, adding platelets will irritate the immune system, generating more antibodies and lead to more platelet destruction. Treatment modalities in this condition include steroids, intravenous immunoglobulins, splenectomy, anti-RH immunoglobulin, and rituximab. Rituximab is a monoclonal antibody against CD20 B cells, which prevent it from producing more antibodies. The fourth contraindication to platelet transfusion is post-transfusion purpura, which is a not uncommon complication of platelet transfusion. In PTP or post-transfusion purpura, the alloantibody is present in recipient plasma, attacks transfused platelets. Treatment here again is intravenous immunoglobulin, corticosteroids, or better plasmapheresis, which means filtration of patient plasma from the alloantibody. After transfusing platelets in its therapeutic doses, we should perform platelet count check 10 minutes after the end of transfusion. If platelet count is not increased, this strongly suggests alloimmunization, or in other words, antibodies against platelets. Second point to consider is to give anti-D or Rh prophylaxis, the Rh immunoglobulin, in premenopausal D-negative women. Although platelets don't carry the Rh or D antigen, but the platelet bag may have PRBCs, especially the whole blood-derived platelets, which will trigger the production of anti-D antibodies that will lead to hemolytic disease of fetus and newborn. As regards ABO antigens, platelets don't require pre-transfusion cross-matches normally required for transfusing cellular components like packed RBCs. But giving platelets which are ABO identical to that of the recipient is the best. The next component is plasma, which is the second most plaque component to be erroneously prescribed after platelets. Types of frozen plasma include fresh frozen plasma, cryo, cryo-reduced or cryo-depleted plasma, solvent detergent-treated plasma, liquid plasma, and F24 plasma. Our Fayoum University Hospital Blood Bank prepared and issued two of them, which are fresh frozen plasma and cryo. Fresh frozen plasma must be prepared and frozen within 18 hours of blood donation. Otherwise, it will lose all its contents. Fresh frozen plasma contains fibrinogen and all coagulation factors, particularly factor 5 and factor 8, which are the lapile coagulation factors. This means that they are rapidly destroyed if not frozen, at least at -20 degrees. Now we will talk about the indications to plasma therapy. As a rule, plasma is prescribed only when other alternatives are not available. Remember this, and we will discuss plasma alternatives in a later slide. First indication to plasma transfusion is bleeding patients with coagulopathy due to multiple coagulation factor deficiencies. The most common cause for this is hepatic failure, which leads to decreased production of all coagulation factors, except factor 8, which is synthesized by endothelial cells. Dilutional coagulopathy from massive transfusion and DIC or disseminated intravascular coagulopathy also lead to consumption of coagulation factors, and definitely it needs fresh frozen plasma. At last, if a patient is experiencing bleeding disorder and the diagnosis is not yet established, fresh frozen plasma is prescribed. Second, fresh frozen plasma is indicated as a rapid tool for reversal of warfarin toxicity before vitamin K administration. Warfarin is an anticoagulant which antagonizes vitamin K, leading to inactivation of vitamin K dependent factors, namely factor 2, 7, 9, and 10. Vitamin K is the antagonist to warfarin, but it takes a longer time, maybe up to 12 hours, to show its effect. and this necessitates fresh frozen plasma transfusion to prevent life-threatening hemorrhages. The famous say is, fresh frozen plasma helps now, while vitamin K helps later. The third indication for fresh frozen plasma is dilutional coagulopathy due to massive transfusion. By massive transfusion, I mean transfusion of 10 or more units of packed red blood cells within a 24-hour period. This will lead to marked dilution of coagulation factors and may cause serious bleeding. Fourth, and as we described before, plasma exchange is a life-saving procedure in the two similar conditions of TTP and hemolytic uremic syndrome. The target is to keep plasma until platelet count reach at least 100,000 per microliter of blood. Fifth, fresh frozen plasma is indicated if the patient is complaining of bleeding tendency due to specific factor deficiency, but the factor concentrate is not available. Examples include factor 8 deficiency in hemophilia A, factor 9 deficiency in hemophilia B, or factor 11 deficiency in hemophilia C. These factors concentrates are available and should be the first line of treatment instead of fresh frozen plasma. The last indication for fresh frozen plasma is the C1 esterase inhibitor deficiency that causes angioneuritic edema, a genetic disease characterized by edematous episodes of cutaneous and mucosal tissues such as lips, eyes, oral cavity, larynx, and gastrointestinal system. This condition can lead to deleterious respiratory obstruction. C1 esterase inhibitor is a complement inhibitor, and its concentrate is also available and should be the first line of treatment. Fifth, fresh frozen plasma is indicated if the patient is complaining of bleeding tendency due to specific factor deficiency, but the factor concentrate is not available. Examples include factor 8 deficiency in hemophilia A, factor 9 deficiency in hemophilia B, and factor 11 deficiency in hemophilia C. These factor concentrates are available and should be the first line of treatment instead of fresh frozen plasma. The last indication is the C1 esterase inhibitor deficiency that cause angioneuritic edema, a genetic disease characterized by edematous episodes of cutaneous and mucosal tissues such as lips, eyes, oral cavity, larynx, and gastrointestinal system that can lead to deleterious respiratory obstruction. C1 esterase inhibitor is a complement inhibitor, and its concentrate is also available and should be the first line of treatment. Contraindications to fresh frozen plasma therapy. Of course, I cannot use frozen plasma for volume expansion to maintain hemodynamic stability as in hypovolemic patients. Here, colloids as albumin or crystalloids as ringer is much more safer. And in contrast, warfarin heparin anticoagulant overdose cannot be reversed by fresh frozen plasma, as fresh frozen plasma contains antithrombin, which potentiates heparin effect. And the antidote here to heparin is protamine sulfate, used in serious bleeding episodes due to heparin overdose. Also, patients with mild elevations in PT or PTT, the prothrombin type, and partial thromboplastin time, to the tests used to monitor for bleeding tendency, mild elevation in these two tests, the patient will not benefit from fresh frozen plasma. And of course, we will not give plasma just for nutrition or well-being or wound healing. As regard doses of fresh frozen plasma, we calculate it at 10 to 20 milliliter per kilograms body weight for adults and 10 to 15 milliliter per kilogram body weight in neonates. However, practically speaking, in adults we usually give 2 bags at a time and monitor by PT and BTT correction. PT, as we said before, is a prothrombin time, and BTT is partial thromboplastin time. These are tests used to assess hemostasis or bleeding tendency. These doses is expected to increase coagulation factor levels by about 20 to 30%. And the effect will be more in patients with greatly elevated PT and BTT than patients with milder bleeding tendencies. Fresh frozen plasma must be ABO compatible to be safely transfused. Now we'll start to go quickly through plasma-derived components or plasma alternatives, which are factor concentrates prepared from plasma and can be given safely without hazards of transfusion or risk of infection transmission. These alternatives must be the first line of treatment considered before fresh frozen plasma. The first of them is the factor concentrates, factor 8, 9, and 11, given in cases of hemophilia A, B, and C. The FIBA or factor VIII inhibitor bypass activity is a factor concentrate used in hemophilia A and B which are caused by the presence of inhibitors rather than the deficiency of factor VIII and factor IX. The prothrombin complex concentrate is an intermediate purity pooled plasma product containing a mixture of vitamin K dependent proteins, namely protein 2, 7, 9 and 10. Next is the recombinant factor 7 activated, which is a concentrate used in many conditions like factor 7 deficiency, which is a coagulation factor responsible for the extrinsic way of coagulation. Can be used also in hemophilia A and B with inhibitors similar to FIBA described in the previous slide, which caused bypassing the presence of factor inhibitors. Also, recombinant factor 7 can be used in case of thrombocytopathy, namely a condition called glanzman thrombasthenia, which causes defective platelet functions. Recombinant factor 7 can be also used in excessive warfarin-associated bleeding. The last in our list is the antifibrinolytics, which are therapies used to inhibit clot lysis and stabilize clot formation. They are considered as a general hemostatics, and the famous two examples include the epsilon aminocaproic acid and the tranexamic acid. Both can be used in bleeding in areas with high fibrinolytic activity like urinary tract bleeding or mucosal bleedings. Next, we'll speak about cryo blood component. Cryo is prepared by thawing fresh frozen plasma, and its main constituents include fibrinogen, factor VIII, von Willebrand factor, factor 13, and fibronectin. Fibrinogen deficiency is the main indication for cryotransfusion, with 10 bags of cryo as a reasonable starting dose if fibrinogen is less than 50 mg per deciliter. The main aim is to normalize very low fibrinogen with a much less volume of fluid administered to avoid volume overload. 150 milliliters of cryo will give the same benefit of 1 liter of fresh frozen plasma. Other indications include hemophilia A, as cryo contains factor VIII, and also we can prescribe cryo in factor 13 deficiency as it contains high concentration of this factor. As we said before, we will give cryo only if the factor concentrates are not available. Other indications for cryotransfusion include von Willebrand disease, due to deficient von Willebrand factor, which is required for stabilization of factor VIII and proper platelet function. Cryo is given only if the intermediate purity factor VIII concentrate containing von Willebrand factor is not available. In severe disease, the dose is 1 bag per 10 kg body weight, every 8 hours until the condition is corrected. In mild forms, DDAVB or desmopressin is the drug of choice. This leads to release of von Willebrand factor from platelets, correcting its levels in plasma. Also, cryo can be used in platelet dysfunction due to uremia as a second line of defense after DDAVB and dialysis. Now, do you remember the last line of defense in treatment of uremic thrombocytopathy? The last component we will discuss is the granulocyte concentrate. The last component we will discuss is the granulocyte concentrate. Granulocytes are white blood cells with granules, with neutrophils being the most important among them. Neutrophils fight against bacterial infections, and if severely deficient, the patient may die from overwhelming sepsis. Granulocyte concentrates are indicated when absolute neutrophil count is below 500 cells per 1 liter of blood. In the procedure of transfusion, it is extremely important to know that blood of donor and recipient must be compatible before transfusion, otherwise a fatal transfusion reaction may occur. As a summary, blood group O is a universal donor and can give all other blood groups, but can receive blood only from O blood group donors. Blood group AB is a universal recipient and can receive blood from all other blood groups, but can give only AB group recipients. Rh negative groups can give Rh negative and Rh positive recipients, while Rh positive donors can give only Rh positive recipients. At last, blood transfusion might not be without hazards, so the dictum here is to use blood products only when no other alternative is left. Here are the references we used, and I encourage all of you to read it. Thank you very much for your kind listening.